Good Friday, everyone. My name is Camilo Gonzalez Velasquez, co-host of the Thyroid by MD's webinar series. And whether you're joining us for the first time or have been with us throughout these sessions, your presence and participation is greatly valued. Today marks a significant milestone as we gather for the 208th time. 4 years ago, amid the early days of the COVID-19 pandemic, we held our first webinar. It's been an incredible journey of continuous learning and discussion, and I'm thrilled to be here joined by our distinguished guests and our dedicated audience. First up, we have Dr. Rajam Raghunathan, currently an endocrine surgery fellow at NYU Langone Health. Dr. Raghunathan brings a unique perspective to our field, blending a strong foundation of general surgery with a rich academic background in philosophy. Her research explores the intersections of endocrine surgery, surgical ethics, and decision-making processes. Dr. Raghunathan's journey began in Ottawa, Canada, where she grew up and took her to McGill University for medical school, followed by residency programs in the University of Toronto and University of Ottawa. Her passion for patient care and advancing medical knowledge led her to NYU Langone, where she is able to tackle complex medical and surgical cases in a diverse environment. Joining her, Dr. Kepal Patel, Vice Chair of Surgery and Chief of Endocrine Surgery in NYU Langone Health. An esteemed leader in his field, Dr. Patel specializes in thyroid, parathyroid, and head and neck tumors. His pioneering research into molecular pathogenesis of thyroid cancer and innovative use of thermal ablative techniques have marked his significant advancements in thyroid and parathyroid disease management. A graduate of the Robert Wood Johnson Medical School and with oncologic training from Memorial Sloan Kettering Cancer Center, Dr. Patel's contributions have been recognized by numerous awards and over 75 peer-reviewed publications. Thank you, Dr. Raghunathan and Dr. Patel, for what promises to be a fascinating session. And thank you, everyone, for joining us today. So let's get started. Rajam, the floor is all yours.
Thank you so much to ThyroPlus and MDS for this opportunity. I have no relevant financial disclosures. Thyroid nodules are common, and most of them are benign. Found anywhere from 8 to 60% on autopsy series, the rate of malignancy of thyroid nodules remains low at around 5%. When a thyroid nodule is found clinically on exam or incidentally on imaging, a biochemical and radiological workup ensues. The initial tests are biochemical, as you all know, a TSH to determine if the nodule is active or not, followed by imaging with ultrasound or a radioiodine scan to further characterize the nodule. Ultrasound imaging is used if the nodule is non-functional, that is, if the TSH is low or normal. The size and ultrasound characteristics of the nodule, defined by TIRAD's classification system, help scope out whether the nodule warrants a biopsy. So that's that center box there that sort of tells you, look, this is an inactive nodule with certain features, and we'll go over those features on the next slide. The TIRAD's classification system looks at 5 sonographic features of the nodule: its composition, echogenicity, shape, margin, and whether it has any echogenic foci like calcifications to help risk stratify it and determine its management. That is, whether it should be just surveyed continuously or whether it warrants a biopsy at that time. Fine needle aspiration biopsy, as I think all of you probably know, is performed under ultrasound guidance for nodules with intermediate to high-risk features over 1 centimeter, low-risk features over 1.5 centimeters, and very low-risk feature nodules over 2 centimeters. Nodules that are smaller in size in each TIRAD's category should be surveyed annually, with a biopsy performed if there is growth or change in the nodule characteristics or new clinical symptomatology. The biopsy aspirate is sent for cytopathology, which is used to further characterize and risk stratify the nodule via the Bethesda classification system. Here's a chart that shows the familiar Bethesda categories from 1 to 6, their corresponding cytopathology, frequency of and malignancy rate, and the suggested management prior to the availability of molecular testing, which is what we're going to discuss next. Management for low risk, that is Bethesda 1 and 2, as well as high risk Bethesda 5 and 6 nodules is pretty straightforward. You repeat the FNA if it's non-diagnostic, you follow up if it's benign, Bethesda 2, and you can then counsel surgery if the nodule is suspicious for malignancy at Bethesda 5 or confirmed malignant at Bethesda 6. It's that middle category there, Bethesda 3 and 4 nodules, which fall into the indeterminate category, and their management is a matter of ongoing discussion and debate. You may wonder why this matters. So it matters because of the prevalence of indeterminate nodules and their malignancy risk. Of the 600,000 FNA biopsies performed in the US annually, 30% have indeterminate cytology. And the risk of malignancy in nodules with indeterminate cytology is between 10 to 40%, so not insignificant. Historically, there were two options for the management of indeterminate nodules. Either you would repeat the FNA biopsy to see if the diagnosis can be clarified with a subsequent sample. So that's that 30% of the 600,000 FNA biopsies. You would have to sort of decide, am I going to, rebiopsy this patient, put them through that again, and see if I get a more diagnostic sample? Or do you offer surgery to remove the affected side, which is considered both diagnostic and therapeutic? Surgery, however, is not without its disadvantages, including increased healthcare system costs, potential financial toxicity for the patient, and patient risks of hematoma, nerve injury, hypocalcemia, and the need for lifelong thyroid hormone replacement therapy. Currently, 1/3 of indeterminate nodules, however, are sent for some form of molecular testing in the United States. Up to 90% of patients with benign results on molecular testing are managed non-operatively. This means that about 25,000 patients per year have reduced morbidity and costs of surgery. The recommended scope of molecular testing continues to evolve and change. The 2015 American Thyroid Association guidelines for the management of adults with thyroid nodules and differentiated thyroid cancer recommended molecular testing or repeat FNA for indeterminate thyroid nodules after consideration of clinical and ultrasound features to supplement the assessment of malignancy risk. 5 years later, the 2020 AAES guidelines for the surgical management of thyroid disease in adults recommended consideration of molecular testing when the need for surgery remains in question, after consideration of clinical, radiological, and cytological features. But the guidelines also caution that the accuracy and utility of molecular testing depended on the institutional malignancy rates. And we'll talk about why and what that is in just a second. As of now, the current landscape in molecular testing is quite rich. There are a number of different molecular testing platforms currently available. The three most common and the ones that we'll focus on today are Afirma Genomic Sequencing Classifier by Veracyte, ThyroSeq Genomic Classifier by Sonic CBL Path, and ThyGene Next Thyromere Oncogene Panel by a company called Interpace. So first, let's talk about Afirma Veracyte. Afirma's gene expression classifier was its first prospectively validated molecular test and became available in January 2011. It used RNA-based genomic expression classifiers and used machine learning to measure the expression of 167 genes by microarray. On validation studies, GEC achieved a sensitivity of 90% and a specificity of 52%. Remember, with these molecular tests, what you want is a high sensitivity and negative predictive value, because what you want to do is rule out something. You don't want to miss a cancer, because that would be devastating as a consequence. Afirma's genomic sequencing classifier was developed and available in 2017. It used next-generation mRNA sequencing with upstream classifiers trained on data sets that included more challenging cytology, like oncocytic or Hürthle cell nodules. On validation studies, GSC achieved high sensitivity and improved specificity. It had a benign call rate of 64%, a positive predictive value of 47%, a negative predictive value of 96%, in a cancer prevalence of about 24%. To improve test specificity, Afirma GSC includes an expression atlas, XA here is the abbreviation. It uses RNA sequencing data to identify mutation variants and gene fusions for all GSC suspicious nodules. As of March 2023, this expression atlas panel is reported for all Bethesda III and IV nodules with suspicious GSC results and is available for nodules with Bethesda V or Bethesda VI cytology. Variant and fusion information, if available, will automatically be reported. DNA analysis for mutation in the TERT promoter region associated with thyroid cancers with more aggressive behavior is also now available as an add-on test. And there's a screenshot of a sample report that shows a results summary from a sample expression atlas overview. All right. ThyroSeq is the next test to discuss. ThyroSeq's multi-gene genomic classifier is a DNA and RNA-based test for somatic mutations, and it was originally introduced as a 7-gene panel in 2007. The 7 genes that were originally on that panel are spelled out in that highlighted violet shade there. The original test had high specificity, but lacked high sensitivity to rule out malignancy. So it didn't quite meet the criteria that we want in an effective molecular test, given our purposes. Version 2 of ThyroSeq became available in 2014 and included an expanded 56-gene panel with a diagnostic sensitivity of 90% and specificity of 93% in a limited validation study. The results achieved in external validation studies, however, showed lower than expected specificity and positive predictive value. Its current version, ThyroSeq version 3, multi-genomic classifier, which is available since 2017, was expanded to 112 cancer-related genes, including over 12,000 mutation hotspots and over 150 gene fusions. Using targeted DNA and RNA next-generation sequencing to identify genetic alterations, including mutations, gene fusions, gene expression abnormalities, and copy number alterations to diagnose or rule out malignancy. ThyroSeq V3 provides risk stratification into low, intermediate, and high risk of malignancy. Validation studies demonstrated a benign call rate of 61%, a sensitivity of 94%, and a specificity of 82%. With a 28% prevalence of cancer, the positive predictive value in indeterminate nodules was 66%, while the negative predictive value was 97%. The improved sensitivity to detect malignancy was attributed to the increased number of genes tested for mutations, fusions, abnormal expression, and in particular, copy number alterations. Copy number alterations are found in about 7% of PTCs that lack other driver mutations. About 38% of oncocytic, formerly known as Hürthle cell adenomas, and approximately 81% of oncocytic carcinomas. So those improvements in upstream classifiers or cassettes trained on oncocytic nodules really helped push ThyroSeq V3 to the next level. The last test that we're going to discuss briefly is ThyGeneNext and Thyromere. It's a 2-step test that uses DNA and RNA sequencing, that's the ThyGeneNext part of the test, followed by a microRNA expression classifier, that's the Thyromere part. This consists of an algorithm of 10 microRNAs previously validated on nodules with known malignancy. The ThyGeneNext panel identifies DNA mutations, while the microRNA panel identifies the number of fusions. TERT and ALK mutations were added to help predict biologically aggressive disease. The test can be performed on cytology slides, which avoids the need for an additional or repeat FNA to obtain a molecular test sample. The test is run in sequence. So first, the ThyGeneNext panel is run on the sample, and if it's negative for malignancy, then Thyromere's microRNA classifier is run to increase the test specificity and sensitivity. In its 2015 validation study, ThyGeneNext and Thyromere demonstrated a benign call rate of 61%, sensitivity of 89%, specificity of 85%, and a positive predictive value of 74%, with a prevalence of cancer of 32%. 2 small retrospective single institution studies showed lower sensitivity, 48%, and specificity of 71%. In comparison with Afirma GSC and ThyroSeq V3, however, there's very limited external validation confirming its performance and clinical utility. In particular, its use as a rule-out test to allow patients with a negative result to avoid surgery. So limited data in comparison to the other tests. So the real-world choice of a molecular test for clinical use needs to take into account several factors: the diagnostic performance of that test, the institutional rate of malignancy, nodule cytology, and the potential for prognostication. So let's look at each of these in turn. In terms of the diagnostic performance of the test, this was an interesting study that looked specifically at this issue. A recent randomized single institution trial out of UCLA prospectively compared the diagnostic performance of Afirma GSC and ThyroSeq V3, and it showed statistically similar sensitivity, 100% versus 97% respectively, specificity, 80% versus 85%, and positive predictive value, 53% versus 63% of the two tests at a 20% institutional prevalence of malignancy. So again, this study sort of confirmed that the two tests were neck and neck. This was a meta-analysis of 40 studies that concluded that ThyroSeq V3 has a slightly better sensitivity and specificity compared to Afirma GSC in all indeterminate nodules, and that both tests were superior to microRNA-based testing. The next consideration when trying to choose a test for your particular situation is to look at the institutional rate of malignancy. Due to the consequences of a false negative result. So as we said, a missed cancer is the clinical consequence of a false negative result on a molecular test that way. Molecular tests were developed with a high sensitivity and negative predictive value to rule out malignancy and to help patients avoid unnecessary surgery. Measures like positive predictive value and negative predictive value, however, statistically depend on institutional prevalence. A prevalence that is lower than average of malignancy can limit the generalizability of results. So for each of these studies, when they're offering their performance characteristics, it's important to keep an eye on the prevalence of malignancy rate that they're quoting. Usually it hovers around 20 to 25% in a lot of these bigger validation studies. All right. Choice of test that looks at nodule cytology and prognostication. Outside of the initial validation studies, almost all molecular test studies suffer from a lack of histopathological assessment. This is for nodules with benign or negative results, since those patients generally avoided surgery, and many of them lack long-term surveillance, just given the duration of these studies. Long-term, multi-institutional prospective data is necessary to confirm the role of molecular testing to allow patients to avoid surgery on the basis of benign or negative test results, and to inform treatment decisions for positive or suspicious results. Depending on patient and ultrasound risk factors, the prognostic information provided by ThyroSeq V3 may help guide the initial extent of surgery. The Afirma Expression Atlas panel may offer similar information, but requires further clinical validation. Ongoing areas of investigation in molecular testing, and there are many of them, but I chose just 4 to focus on very briefly here, are oncocytic cytology, BRAF V600E, NIFT-P, and the cost-effectiveness of these platforms. Oncocytic nodules, formerly known as Hürthle cell, continue to pose a diagnostic challenge, given their ubiquitous presence in neoplastic and non-neoplastic thyroid tissue. Preoperatively, distinguishing benign from malignant oncocytic lesions is critical for appropriate management, given the aggressive disease biology of invasive oncocytic carcinoma. Either molecular test version, in particular Afirma GEC, earlier molecular test versions, in particular GEC, suffered from poor performance with a high false positive rate in the oncocytic subset of indeterminate nodules. Improvements in upstream classification cassettes in Afirma GSC helped increase the specificity to 59 to 83% in the oncocytic subset, while the benign call rate improved from 16 to 26% for GEC to 71% for GSC. This is specifically for that Hürthle population of cells. Data on the clinical performance of ThyroSeq V2 in the oncocytic nodule subset is limited, but ThyroSeq V3 displayed a specificity of 64% in oncocytic nodules and a benign call rate of between 48 and 61%. The diagnostic performance of current molecular testing in oncocytic nodules requires ongoing clinical validation. BRAF V600E is one of the 2 mutually exclusive driver mutations, along with RAS, or RAS, identified in papillary thyroid cancer. Along with being very common in PTC, about 80% of them are found in tall cell variants, 40 to 60% in classical variant, and 30% to 70% in papillary microcarcinoma. The presence of a BRAF V600E mutation has been associated with an advanced disease stage and reduced radioiodine responsiveness. When found in combination with a TERT promoter mutation, BRAF V600E is associated with aggressive disease biology and both local, regional, and distant metastases. Clinically, tumors with BRAF V600E show diverse biological behavior, and there are some recent studies, and I've included all of these in the references to the presentation, which have shown that ethnicity, age, and sex are robust risk factors for PTC-specific mortality in BRAF V600E cancers. All right, so this was sort of a radical shift in the thyroid cancer world, but in 2016, non-invasive encapsulated follicular variant of papillary thyroid cancer, EFV-PTC is its acronym, was reclassified to non-invasive follicular thyroid neoplasm with papillary features, or NIFT-P, that's its acronym, which is a precursor lesion to invasive EFV-PTC. This change was made to reduce overtreatment of what was essentially a premalignant lesion with very indolent behavior. The 2017 ATA guidelines recommended that NIFT-P be managed with lobectomy alone, and molecular testing has continued to refine our understanding of this diagnosis and its management. In 2022, a study of consecutive patients with NIFT-P over a 5-year period, 84 nodules were identified, and 74% underwent preoperative molecular testing, mostly with ThyroSeq. Molecular testing was positive in 94% of those cases, most commonly with RAS-type molecular alterations. No BRAF V600E, TERT, or other high-risk mutations were observed in that set. And most patients with NIFT-P in the study were treated with lobectomy alone and had no evidence of recurrent disease during the mean 28.5-month follow-up period of the study. The benefit of molecular testing to help avoid unnecessary diagnostic surgery and potentially inform the extent of surgical treatment has to be weighed against the significant costs of each testing platform, particularly at a system level. A recent study estimated that molecular testing resulted in a 20% reduction in the use of diagnostic lobectomy and a corresponding increase in initial total thyroidectomy when appropriate. Performing an upfront total thyroidectomy was less than the cost of initial lobectomy followed by completion, even considering the added cost of molecular testing. And there's a cost comparison there in US dollars. So, this is another kind of consideration when looking at whether and how to start implementing molecular testing in your health system. All right, molecular tests emerged initially with a goal of ruling out malignancy with high sensitivity and a high negative predictive value, but it's continual refinement of their sequencing and classifier systems that have helped improve their specificity. Higher benign call rates have enabled more patients to safely be directed towards non-operative management. And indolent nodules, including NIFT-P, as we discussed, can be identified preoperatively with molecular testing based on their molecular signatures and appropriately treated with lobectomy alone. However, at the moment, the data for molecular testing still can't trump surgical histopathology, which means that the gold standard which means it remains the gold standard in the diagnosis for thyroid cancer, that is surgery. Molecular testing offers the potential, however, for preoperative prognostication and risk stratification in patients with Bethesda V and VI cytology through the creation of something called molecular risk groups, or MRGs. ThyroSeq V3 has been used to stratify thyroid cancers into MRG high, including TERT and TP53 mutations corresponding to anaplastic thyroid cancer, poorly differentiated thyroid cancer, and tall cell PTC histopathology. MRG intermediate, which include mostly isolated BRAF mutations and classical PTC on histopathology, and MRG low. These are RAS-like mutations with NIFT-P and FVPTC on histopathology. It was estimated that the 3-month recurrence-free survival for MRG high, intermediate, and low disease was 56%, 91%, and 100%, respectively. All right. We still do need long-term studies of patients with indeterminate nodules who underwent molecular and non-operative management. Who underwent molecular testing and non-operative management, with surveillance and long-term surveillance data needed to gauge test reliability, false negative rates in these cohorts, and the optimal duration of ultrasound surveillance. Decision-making needs to incorporate clinical risk factors, sonographic nodule characteristics, patient values, preferences, as well as molecular testing results when available. So that's the current and past, current, and future state of things. That concludes my side of the presentation, and I'll just leave you with some reference slides right here.
Thank you. Thank you very much for your presentation. This was a very good review of what has been the panorama of use of molecular testing in the past decade or so. I'm really looking, I have a couple of questions, but I'm really looking forward for Dr. Patel's discussion, and we'll come back to the Q&A at the end of the hour.
Excellent. That was a great talk, Rajam. We're super proud of you at NYU. So let me, she's also my fellow, so I have to be very nice to her. So I'm going to put on my share screen. Give me 1 second here. Perfect. Awesome. So I'm going to follow up on all the wonderful things that Rajam just said, kind of put things in a little bit of context. She gave us tremendous amount of information condensed into that talk. So I'll try to distill it a little bit and just try to make it more practical on how we utilize molecular testing. So I have no disclosures. Nobody pays me to say anything, which is, I guess, good and bad. So molecular testing. When I think of molecular testing, I really think of it as in the preoperative setting and in the postoperative setting. What are we using it for? In the preoperative testing, is it a rule-in test? Is it a rule-out test? And these are terms that we've used for the last, decade or plus now, since, the first paper came out in New England Journal of Medicine. And so, in essence, to me, if I have a benign appearing nodule on an ultrasound, I'm not too concerned about it, but the cytology comes back of Bethesda 3 or 4. I like to use that as a rule-out test. Like I want to make sure it's not, I don't want to take this patient to the operating room and find out it's benign, which most likely we know from historical data that those nodules are most likely to be benign. Conversely, sometimes I am thinking about, hey, this nodule looks pretty aggressive on my sonogram. So you have to put everything in the clinical context of what you're trying to achieve, your physical exam, your history, your ultrasound features and findings, and then try to see how these molecular markers can fit into that process. And also from a risk stratification standpoint, which we'll talk about again briefly, which Rajam just talked about, looking at molecular risk groups, et cetera. The other way we talk about molecular markers and molecular testing is in the postoperative setting. This is usually once the tumor has been removed, we're trying to see if it's a very aggressive type of tumor. Are there targetable mutations? Can we use a molecular profile to potentially prognosticate the tumor to help us in our surveillance or follow-up or further treatment? So, you kind of have to differentiate in your mind what are you trying to achieve by getting this information? So once again, like I already summarized, what are you trying to achieve, and how can these molecular genomic tools help our patients, right? So molecular diagnostics is really born out of indeterminate cytology. So we know when you have a benign nodule, it's a low risk of cancer, and most likely you're going to either repeat the imaging or repeat the FNA. If you're concerned or worried. If you have a malignant nodule, it's going to be, or suspicious for malignancy, it's probably going to be high risk of cancer. And at that point, you're already thinking, what's the best option for this patient? Is it going to be a lobectomy or total thyroidectomy? If it's a small cancer, active surveillance, observation. So it's really born out of indeterminate cytology, which we already discussed. So the optimal management is not clear when we have indeterminate cytology. And that's really kind of what gave birth to the concept of molecular diagnostic testing. And a lot of this information, I mean, this paper is almost 10 years old now. We're all familiar with this paper from Tom Giordano and Cell, looking at, our thyroid cancer genome atlas. And they really, we've identified almost all the driver mutations in papillary thyroid cancer, right? We know there's somatic mutations. 76% of, of all the thyroid cancers are driven by these somatic mutations. There's gene fusions, and there's, copy number alterations, right? When you put all this information together, we have this information. We know what the mutations and the genetic aberrations and abnormalities are when it comes to papillary thyroid cancer. And using this information, we have come up with these different genomic tools, which I'm not going to go through again at all, because Rajam did such a great job of talking about Afirma and the GEC, followed by the GSC, and now the Expression Atlas, the ThyroSeq, and the Thygenix and Thyromere tests. So we know these tests are out there. Yeah, I'm not going to go into details about anybody's tests any further. We've already kind of discussed that. I'm happy to talk more about them if we have any questions during the discussion. But in general, I like this table here. This was published by Sally Carty's group in Pittsburgh in 2023. And it kind of goes through these tests and a summary of these tests. And you kind of see, the analytic validity of both Afirma and ThyroSeq is pretty robust. With the Thygenics, it's still limited. It still needs more studies to kind of confirm, its real validity, the clinical validity, the accuracy. Similarly, for the Afirma studies, there are several studies now out there. There are several ThyroSeq studies that Rajam already spoke about. The benign call rate is good across the board. So that's the one thing you got to remember from a rule out perspective, from a negative predictive value perspective. These tests are all really good. They're all 95 plus when it comes to the negative predictive value, right? That's what these tests were all initially designed, is to take these indeterminate thyroid nodules, most of which are going to be benign, remove them so that they don't end up in my clinic and I don't end up taking them out. And this way, the patients can be spared surgery. And you do surgery on the patients that need the appropriate surgery. Once again, the clinical utility, we already talked about. Cost, Rajam, and I'll talk a little bit about that in a couple of seconds again. And once again, if you go down this into prognostic use, once again, we're not really sure. It's kind of unknown. ThyroSeq has come up with some studies showing its clinical validity and prognostication, but once again, it needs further confirmation and more kind of multi-institutional studies. And there's really nothing, and we'll talk a little bit about this when it comes to surgical extent and the use of molecular testing. This was already discussed by Rajam, looking at our molecular risk groups, right? And so this is a paper by Linhua Yip, also from Pittsburgh back in 2021. And it kind of correlates really well with our ATA high risk, intermediate, and low risk categories, right? So the ThyroSeq, high risk, mutational group, you see, it correlates really well with the high risk ATA group. Similarly, the intermediate risk correlates really well with intermediate risk from a clinical standpoint, and the low risk correlates really well with the low risk from a clinical standpoint. So the molecular risk groups really do kind of, correlate with our clinical risk groups, and that's important. So we know now when we have these clinical findings, what are the molecular associated changes that are occurring that are giving us these high risk categories, intermediate and low risk category situations. So when and when not to get molecular testing? Well, this came up from the American Association of Endocrine Surgeons guidelines a couple of years ago, and molecular testing is really used to examine genomic changes that are utilized in thyroid disease as a preoperative adjunct to refine the risk of cancer and cytologically indeterminate nodules, right? And one of the recommendations that we came up with is if you're going to be doing the thyroidectomy anyway, for whatever reason, patient has a 4 or 5 centimeter nodule, you don't like the way it looks, patient wants it out anyway, it's not going to change your management, then getting molecular testing on those patients may not be necessary. And so you have to put, once again, your utilization of these tools into the context of what are you trying to achieve. If it's not going to change your surgical management, then you don't necessarily need to get molecular testing on every single patient. And that was our thought process. So if thyroidectomy is indicated regardless of cancer risk due to symptoms, imaging features, nodule size, then ordering molecular testing for the purposes of avoiding surgery would probably not be indicated because you already made the decision to do surgery, or the patient already made a decision to have surgery. If multidisciplinary management of cytologically indeterminate nodules lead to an observation based on locally available radiologic and cytologic expertise, then the clinical utility of molecular testing, once again, is diminished. So these were some of our indications as to when not to get molecular testing. Then we came up with recommendation 11. When the need for thyroidectomy is unclear after you consider your clinical findings, your imaging, your cytologic features, that's the situation where molecular testing may be considered as an adjunct for these indeterminate nodules. And once again, as Rajam pointed out very, very nicely, the accuracy of these tests really relies on your institutional malignancy rates, and it should be locally examined for optimal extrapolation of results to your thyroid cancer risk, right? So I know at NYU, when our cytopathologists call something Bethesda III or Bethesda IV, looking back at our historical data, there's pretty much a 30 to 35% risk of malignancy. There's not that much of a difference between a Bethesda III and Bethesda IV call rates. If you take them all to the OR, what the risk of malignancy is, and we've discussed this with our cytopathologists. I think, I'm talking about data that's probably 5 to 6 years old now. I feel like it may be a little bit different. We're never going to do that study again because we're not going to take all these patients to the operating room because we do use molecular testing. So this is data that we looked at prior to molecular testing when all these patients went to the operating room, and we knew what our call rates were for Bethesda III and IV nodules. So I encourage people to understand what their institutional call rates are and talk to your cytopathologist because there's so much variability. I mean, it was a great paper published back in 2013 by Sebas et al. Looking at the inter and intra variability in the cytologic diagnosis. And even the same pathologist looking at the same slide 1 month later only had a concordance rate of about 75 to 80% when it came to Bethesda III and Bethesda IV nodules. So 20% of the time, the same cytopathologist would call it something else, looking at the same slide. So that goes to show you that the concordance rate is variable when it comes to cytopathology. So you really need to understand your institutional rates. So as far as using molecular testing to guide the extent of surgery, so to date, no molecular test has really been studied for surgical guidance under the 2015 guidelines. When now we're coming out with new guidelines, hopefully in the next couple of months, ATA guidelines, so we'll see what that shows. But to be useful for deciding extent of surgery, first of all, it has to give you reliable prognostic information. And overall, the prognostic value of molecular testing is limited when histologic features are already available for refined risk stratification. So for example, if somebody comes in with a 5 centimeter fixed mass, multiple lymph nodes in the neck, molecular testing is not going to change what that. I know that patient has an aggressive tumor. It's going to need a total thyroidectomy, probably going to need a neck dissection. Most likely may need radioactive iodine. So that decision has already been made. Does it matter whether the patient was BRAF or TERT positive? Maybe afterwards, we may want that information for further targeted therapy, but it's not going to change my management as far as the initial treatment is concerned. So we still need more data to really determine if genotype provides any additional information that's already not available clinically or by your imaging studies to determine whether the extent of surgery based on molecular testings will affect outcomes. And a classic example that people always talk about is, you have this 1 centimeter nodule that for some reason is indeterminate, and molecular testing comes back BRAF and TERT positive. And you always say to yourself, well, I would have just done a lobectomy on this tumor. The other lobe is completely normal. The fact that it's BRAF and TERT, would I consider doing a total thyroidectomy? And I think the jury is out on that, right? I think there's many of us that would say, well, it's an aggressive molecular profile. Maybe I'll go ahead and do a total. But I don't think anybody's shown that doing a total on that 1 centimeter tumor is providing that patient with any better prognostic future than just doing a lobectomy on that patient. We don't have that information. I don't think we can make that call yet. Real quickly, cost effectiveness. I think Rajam already touched on these, but basically, most of the studies out there right now do show in hypothetical modeling that molecular profiling, molecular testing is somewhat more cost effective than taking the patient straight to the operating room. And it kind of makes sense. You're saving X amount of patient surgery, so to some extent it is going to be cost effective. And the bottom paper actually showed using molecular testing in a reflexive fashion as opposed to just doing it selectively was also still more cost effective. So I'm going to stop by just giving this one. This is a case that myself and Steve Hodak in our institution, we share this patient. So this was just kind of give you an idea how we utilize these tests. This was a 56-year-old male with a 4 centimeter left thyroid nodule found incidentally. He comes from an area that's endemic for goiters. He's lived in this country for about 30 years. Easily palpable left-sided mass, no palpable lymph nodes. Exam was otherwise unremarkable. This is what the lesion looked like. The right side was pretty much normal. And the FNA came back Bethesda III, nuclear atypia, colloid was present in the background. And for this nodule, what's the risk of likelihood of cancer? Is it high, low? Not sure. It's pretty well defined. There's no evidence of extrathyroidal extension. Bethesda III nodule, atypia. You may make the argument, well, I'm probably going to take this out anyway. It's 4 centimeters. Do I really need to get molecular testing? And so a left lobectomy is absolutely reasonable. Would you do a total thyroidectomy in this patient? I mean, there may be people that may say that. Probably not necessary without any further testing with a Bethesda III nodule. Would you just observe it? Well, you can repeat the biopsies. Bethesda III, it's a discussion with the patient, obviously. or would molecular testing affect the management? And so is surgical management reasonable? This patient actually had a NTRK 3 fusion, ETV6. And so for this patient, we know now with this mutational profile that this is going to be most likely a malignancy. So this patient actually, we know that this particular mutation activates the MAP kinase and PI3K signaling pathway. It's usually associated with follicular variants or classical variant PTC, solid infiltrative growth patterns, and it's not reported in benign neoplasms. So now we know that this 4-centimeter tumor is most likely a malignancy. So now with 4-centimeter cancers, you can say, well, yeah, I could do a lobe, I could do a total. You're kind of on the fence. This patient underwent a total thyroidectomy because in the operating room, we actually did see some lymph nodes. Vascular invasion was present. Extrathyroidal extension was present. She had 4 to 4 positive central nodes. Largest focus was pretty large, and there was no extranodal spread. And in the post-surgical, 7 days later, post-RAI scan, showed some uptake in the lung. And the patient had now a metastatic focus in the lung from this positive NTRK fusion. And so does this have any clinical significance? Well, it turns out that it does, because we do have targeted therapies for this particular mutation. So in this patient, it was actually nice to have this information. It avoided us of potentially doing a lobectomy and having to go back for a completion. We knew what the mutation was. This patient, unfortunately, did have a distant metastatic focus for which we do have a targetable. This mutation is a targetable mutation. We do have drugs to target this particular mutation. So identification of specific oncogenic drivers can give us prognostic information as well as potentially druggable targets. So I'm just going to conclude here and leave some time for any questions. All molecular genetic tests have limitations, right? We talked about Diapharma and ThyroSeq, the largest validation studies. There's still valid criticisms on both studies. They exist. The Thygenics, Thyromere group have very small validation studies. There's still more additional confirmation validation is still needed. There are prognostic implications when it comes to using molecular testing. And when we use molecular testing of biopsy-proven cancers, we're trying to do that for risk stratification management decisions. A problem with biopsy-proven cancers, it's usually not covered by insurance. And so it requires another extra step to kind of figure out why you actually want that on tumors that are already Bethesda 5 or 6. Mostly 6, not 5. This style, I'm going to give courtesy to Steve Hodak because he always puts this up in his talks, and I love this slide. So when it comes to diagnostic tests, words to live by, there are 3 types of lies, damn lies, and statistics. Not sure who said it first, Mark Twain or Benjamin Disraeli. Torture numbers long enough and they will confess to anything. So when you read these studies, when you look at these studies, really got to understand, the statistics behind it. And the law of small numbers, right? Biases that occur when it is assumed that the characteristics of a population can be estimated from a small number of observations and data points. So we have to keep that in mind also. So on that note, I'll say thank you, and we can open it up to discussion, I guess.
Thank you. This was really interesting. I love the way that you went through this data and how you brought it down with a case. I had some questions in my head, but right now I can't stop thinking about those quotes that you gave us on how to lie with statistics and how you can't assume things with small numbers or small samples. So going back to that, the vast majority of the information that we do have from molecular testing comes from what I call the ivory tower institutions, like big institutions that have the resource to do this kind of molecular testing. And throughout your talk and Dr. Rajam's presentation, we spoke about the institutional risk of malignancy call rate. So how do you extrapolate, or how do you speak to the people out there that do not have that kind of luxury to do molecular testing in AUS or FLUS or you name it? How do you actually extrapolate? How do we stop lying with statistics?
Rajam, I'll let you answer that question.
Oh my goodness. It's a deeply philosophical question.
Exactly. That's why I give it to you.
Yeah, I think it sort of, if anything, it just raises the bar and I think creates the need for institutions to start tracking and to keep better records of their malignancy rates. Getting a sense of working with a multidisciplinary team, speaking to your pathologists, like keeping track of benign and call rates for surgical pathology, so that you can start developing a sense within your institution and within your center. I think if you really have no data and you're starting from like a real center that's in the community that has never tracked these types of outcomes, then probably, a good place to start, and Dr. Patel can maybe correct me on this, but would be to look at studies conducted at places in your region. Because we know that some of the rates of these diseases have to do with geographic features, whether being on a goiter belt or whether the disease is endemic, or there have been certain events that have happened in that area that make certain mutations or fusions more likely. So I think if you're starting from square one and you have no data at all, then just canvassing the literature to see what's available and getting a sense of the range, and then beginning a data collection program to start laying the foundation for using these tests in a more critical and thoughtful way is essential.
Beautiful.
Yeah, I agree. I agree with everything she said. And I think, as I'm going to put on my surgical hat a little bit here, but I think as surgeons, we have the benefit as when we take these patients to the OR, we have their surgical pathology. We know what the information is. We have that data. Often the pathologists, they'll have that data, but they may not have the preoperative data. Or you're referring endocrinologists or primary doctors may have the preoperative data, but then they may not know exactly what happened in the operating room, what we saw in the operating room. So, we do have the luxury of having everything, the preoperative and the postoperative information. And I think, as surgeons, I think it's kind of nice to be able to collect our own data. We do that routinely. And I do recommend that if you're going to be doing molecular testing, if you're starting a program, if you don't have that information, start collecting your own data, right? And then this gives you the opportunity to go back to your pathologists and tell them, hey, like every time you call this, I'm seeing this. And then we can kind of train and teach each other. And I think they really appreciate that. They like, our pathologists here love it when I give them, surgical feedback and tell them, oh, in the operating room, this is what I saw. And they're like, oh, that's great, because, they don't know that, right? They're just looking at a specimen. They have no context as to where that specimen's coming from. So I think that open communication, if you can start a multi-tumor, disciplinary tumor board, where you can discuss these type of cases is very helpful and useful.
Awesome. Thank you. Right now you went over a couple of recommendations where you should or where you shouldn't do molecular testing in a particular case. And it seems really easy or very straightforward, the way that, well, if you're going to do a thyroidectomy, you probably don't need it. When black is black, it's pretty easy to say if you should or you shouldn't use it. However, in 2022, the AHNS came up with consensus of when to use molecular testing, and David Shonka and that group came up with a list of nuances where we can define advanced thyroid cancer, and they gave us kind of a guidelines of where we should be using molecular testing. So going into the more gray zone, not in the where black is black, what do you feel are other uses of molecular diagnosis? Dr. Mark Ricken, he posted one question in the chat where he's saying, are we in the place where we can use molecular diagnostics for all biopsy-proven thyroid cancers? I'm guessing he's going through the prognosis or the extent of surgery or targeted therapy. I know he might be hinting towards that, but what is your sense on when things aren't that easy, when do you use molecular testing?
And so if you look at the risk stratification data that Rajam showed and then that I showed, our molecular risk grouping is very concordant with our clinical risk grouping, right? And so, we have that information clinically. We know the aggressive cancers, when they walk into the office, exactly that cancer is not going to be good. You can just tell by looking at the patient sometimes. And you're right. It's the gray area that we kind of, are concerned about, right? So to answer your question, I think if it's going to, like I said, if it's going to change your management, right, then I think molecular testing is useful. If there's a patient where you're not sure whether maybe we can just not operate on this patient, or maybe like I said, it's still a gray area whether you're going to change the extent of surgery or the extent of treatment for a patient. But if you're unclear and not sure, then I think molecular testing may be useful. To answer Dr. Erkin's question, that's a great. I've always argued in my mind, I've always felt like molecular testing is obviously going to be more helpful in biopsy-proven cancers because that's where you're going to see the mutations, right? The mutations are going to be in the biopsy-proven cancers. Once again, we haven't been able to show that yet because there are really no studies looking at biopsy-proven cancers with molecular testing and in saying whether or not we should change our management on that patients and whether that actually affects the overall outcomes. I mean, we have to remember we're dealing with a disease in general that has a fantastic prognosis. So to really change that prognosis and make it even better, you're going to require a lot of patients and a lot of data to prove that. I don't know if those tests are actually going to be doable. Let's put it that way. But nonetheless, I do think there's validity to getting molecular information in aggressive biopsy-proven cancers where you're thinking nowadays, right? I mean, with the new data coming out, looking at neoadjuvant treatment prior to actually resecting an aggressive cancer that may have, they may have, locally advanced disease that may involve the trachea or the esophagus and may, normally would have done a big resection for those patients. Well, now can we use something that's targetable, potentially, just like many other cancers in the human body? Neoadjuvant treatment's been around forever, to decrease that size of tumor and make that tumor now resectable without the morbidity that would have happened if you did it prior to, treating it. So I think, I think we're evolving. I think, I think this is an exciting time. I mean, with all the data coming out, especially in these really aggressive cancers, conversations that we were having 5 years ago, we're not having anymore. And 5 years from now, we're maybe having a completely different conversation.
So just as follow-up, Dr. Erkin just wrote, but the problem really is the low-risk thyroid cancer with a high-risk molecular risk grouping.
Yeah, that's the example I gave. The 1 centimeter papillary cancer that had a BRAF TERT mutation. What are you going to do?
Exactly.
Right? I don't have an answer. I don't think anybody does. So I'll probably, if you ask me personally, if everything else looks great and the other lobe is completely normal and there are no lymph nodes and everything looks great about this tumor, I don't see a reason why you wouldn't just do a lobectomy and follow this patient more closely. This is an aggressive mutational profile. This patient may be at high risk of local regional recurrence. That patient, I would probably follow a little bit more closely, knowing that information. I don't know if doing a total thyroidectomy up front would have changed that patient's prognosis, because even if that patient does recur in a younger patient, I could always take him back, do a completion. If I need to give them radioactive iodine, give them radioactive iodine, and most likely their prognosis will probably remain the same. I mean, age is still a very, very important prognostic factor for a lot of these patients.
Great. I have another question. When we speak of molecular diagnosis, we always think of the rule-out test, or we think about looking for targetable mutations or fusions, or you name it, that we could use a systemic therapy now with the new drugs that we have directed for those. However, what do you think about the use of molecular testing? Rajam was mentioning how 2016, the thyroid world, I should say, got shifted with the introduction of NIFT-P as part of a diagnosis. But NIFT-P is, or could be, misunderstood, rather not so as a pre-malignant lesion, but as a benign lesion by some physicians, and just let it be. So what do you think about using molecular diagnosis for the surveillance of patients that we don't know the potential malignancy or the potential to become a malignant lesion in time?
No, I think that's a really important point. I mean, I think the take-home point here is that, as you said, NIFT-P is a pre-malignant lesion, and it's also it's a surgical pathological diagnosis. It's not a diagnosis that's made on molecular testing. It's not a diagnosis that's made clinically. You need the histopathology. You need the surgical pathology to say this is a NIFT-P. So it's not, we don't have data to support surveillance of them. The appropriate management remains surgery, but that surgery can be scaled down in the appropriate setting, as Dr. Patel was mentioning, from an upfront total thyroidectomy to a lobectomy, which will both be diagnostic and curative in the case of a NIFT-P. So, while molecular testing continues to advance and continues to push the frontiers of things, as I said in the talk, and as I think, anyone who works on this field and continues to use it has to acknowledge, surgery and surgical pathology is still the gold standard diagnostically.
Thank you.
Yeah, I agree 100%. I mean, for the NIFPs, most of them are indeterminate nodules, and you take them to the operating room, and the final diagnosis comes back NIFP. So we kind of already have the molecular profile on those tumors, right? And they're most likely, most of them are going to be RAS-like tumors with RAS-like mutations. And so usually they're low-grade mutation or mutational profile. So that's why it would be unusual to have a high-grade mutational profile and then final pathology to be NIFP. I would have my pathologist look at that again and maybe have it sent out for a re-review, because if you have a high-grade mutational profile and you're getting a histologic diagnosis of NIFP, which is a low-grade lesion, there's some issue. There's something going on there. So I would just have that looked again, because I would feel uncomfortable telling a patient that they have NIFP and you're going to be fine and don't worry, and have a high-grade mutational profile which is associated with metastatic disease, than to find out 5 years from now it wasn't really a NIFP, it was a follicular carcinoma with angioinvasion. Then you're like, oh, how did we miss that? So I think in that case, when you have a discrepancy between your mutational kind of landscape and what you're seeing at a mutational level and what your pathologist is saying, what it looks like, I think that's where you need to maybe have a better discussion with everybody involved and figure out what's going on.
That is great. And you literally took the words out of my mouth. That was my next question. Like, what do you do when it doesn't coincide with the molecular diagnosis? So that really clears that up. We're coming to the end of the hour here. Before we leave, I want to take a time to congratulate you both for your work, for incredible presentations, for carving out some time to be here with us in this 4th year anniversary session. And I want to invite you and all the audience to be here next week. We are gonna have a panel discussion with Dr. Mark Kirk and a great number of panelists speaking about the history of thyroid surgery in the past century. So we're looking forward to that. I hope everybody is staying safe and wish you all an incredible weekend.